Hello and welcome to the review of myopia management video series. I am John Saylor, Editor-in-Chief of Review of Myopia Management. And we are here today with Tony Caporali, Director of Product Management for X-Cel Specialty Contacts, and optometrist Nicholas McColley of Hancock Eye Associates in Greenfield, Indiana, to discuss the fitting process for orthokeratology lenses. Their insight into fitting OrthoK lenses will provide eye care professionals with the confidence they need to achieve success with this specialization. Tony, Nick, we look forward to an informative discussion about fitting OrthoK lenses.
Thank you, John. I appreciate it. As he said, I'm Dr. Nick McColley. I practice in Greenfield, Indiana. Previously, I practiced in Texas, and in both locations, we had a pretty large specialty contact lens practice where we fit a lot of difficult cases in scleral lenses, OrthoK, and we've used multiple designs throughout the process. Today, we're going to be talking about a case study for myself, actually, because I'm a very, very difficult patient, as I found out starting in optometry school. My first time trying to be fit in OrthoK lenses, I was in optometry school and I had a few professors perplexed. We couldn't just get the fit right. So recently I started to try again. And I started a few months ago. And as you can see on this slide here, my pre-treatment refraction and Ks should be a slam dunk in terms of orthokeratology. I should, with a -2.5 spherical equivalent prescription and fairly normal Ks, most OrthoK designs should have fit on my eye very well. My problem is that with my eyelids, I pull all lenses up, scleral lenses, OrthoK lenses, and all of them decenter, providing poor optics and fit. So I have a few different factors. My visible iris diameter is a little bit larger than most. It's 12.4 millimeters in each eye, and my eccentricity is 0.57. So I started off with the traditional OrthoK design, and you can see my topography there. Going to the next slide here. My first lenses, I was fit in a dual axis design because I had told the consultants that I was working with that lenses tend to decenter up on my eyes. So they thought, let's start with a larger diameter lens for a larger cornea and a fit that we've had trouble with in the past, with a dual axis design to try to get the lens to center a little bit more appropriately. So we tried that based on my Ks and refraction. And after a few nights of treatment, I really didn't get much in the way of vision improvement. And in fact, I had increased quite a bit of cylinder and aberrations in my eye, making vision pretty bad. The edge fit of the lens was also poor. The dual axis design provided one meridian with the edge lift a little bit too much, allowing too much fluorescein underneath when you look at it under slit lamp. And the other one was very, very thin around the edge. So then we made a second lens where we did not
step in. Can I step in, Nick? From the consultative side, I think that's great information. If we just got the minimal amount of information, which would be Ks and refraction, which most OrthoK lenses are designed from, we would have considered it the same way as you put it, a slam dunk. This should be a really easy fit, a lower myope with a nice K reading. But you interjected with more information and gave that to the consultative team, which is really very helpful. With the more information we get, the better off we are in helping the fit. I necessarily wouldn't have gone anywhere outside of a normal design. Getting even the information that you provided, I would have started with a normal design. But you can see that going to the larger diameter may have helped the situation in that. Another thing that I would interject is, when we're looking at the design and the effectiveness of it, if that lens is not centered well, we're really dead in the water. We really have to get that lens to center first before we evaluate the rest of the lens. So I think that's important. But the main point, what we can get as information, as much as we can get from the consultative side, it will help in that initial fit and moving on with the fit in the future.
And that's exactly right, Tony. The more information, the better. And, I probably saved 3 lenses just from the starting point that we had, because of the previous experience that I'd had. So after that first lens failed, we tried a second lens with that same company. And what I did here is I went into the dispensing set that I had for that company, which is a 10/6 diameter. And I put lenses on the eye until I got a good treatment zone. And that happened at an 8/4 base curve. So then we took out the dual axis design, flattened the base curve, and made the diameter a little bit smaller, an 11/0. I wore it for 3 nights there, and then I got much, much more treatment, but I was still getting some aberrations. And actually, the lens was a little bit too flat for me because my over refraction in the lens was a plus 125, but I only got down to a minus 50 refraction. And as Tony said, I'm a difficult patient because I have high visual demands. And so if you put a 15-year-old kid into ortho-k and they have 20/25 vision with some aberrations, they may not care. But if you take
They can
a
adapt
doctor,
very easily.
yeah. But if you take a doctor or somebody that's type A and high visual demands and high expectations like myself, it's going to be a tougher fit. And so setting expectations on the front end is very important for the people that you are fitting. And I just have the luxury of being able to experiment and tinker a little bit, to make sure I get a good fit.
And
So
you make a great point, setting the expectations. And that's what we have to do as consultants, and you have to do as a practitioner when you're speaking to the patient. But as a consultant, if I see anything that is abnormal in the realm of ortho-k, or what we're usually fitting by the parameter standards that are set by, if it is VST or CRT, they have set parameters. And if they're outside of those parameters, or if they're flatter than usual, or if they're a larger HVID, you have to set the expectations for the practitioner. Okay, this may take another lens that we're going to have to utilize down the road. Those expectations, when you set them at the forefront, really help the situation as we move forward.
absolutely. And that's a conversation that's a must have with every patient. So if we look at the topography for this 8/4 base curve lens, you can see that there is a ring of treatment around the outside of the mid-peripheral cornea, but in the center, we get some residual astigmatism. And actually this topographer shows to the right what different optotypes will look like to me with the aberrations. And as somebody with very little normal everyday aberrations, this was just absolutely driving me insane. So on the third set of lenses, we backed off on the base curve down to an 8/3. Here, this was the best fitting lens. We kept it not dual axis, but we did go back to a larger diameter again, an 11/5. This was the best centering lens that I had with this company and the best vision. I got to a 20/20 vision. I had a plus 50 refraction, so very, very good treatment, but I was still getting the aberrations. And so what I did is I took a diluted pilocarpine drop and put it on my eyes, thinking, hey, if I get a smaller pupil size, will this make my vision better? And it sure did. It made everything significantly clearer once my pupil got inside that treatment zone. So as we look at the next topography, when I finally got a brand new topographer that looks significantly better, the treatment zone in the center there is very small. Now, I'm early 30s, myopic patient, and so my pupil with blue eyes, and so my pupils are pretty big. And even in daytime settings, my pupil was not getting small enough to fit into that treatment zone. So this is when I started working with REMLens. With REMLens, I'll let Tony discuss the design of it and where we went, but I basically presented Tony with this problem and I said, how can you help me? So Tony.
So 2 things that I would like to point out with REMLens and the development of it that took, several years, was we needed to look at the older designs, and maybe not antiquated, but older, that were developed for straight ortho-k. And we wanted to adapt it to also be a part of myopia management. And part of what you need when you're designing lenses or when you're utilizing a design is manipulation. So we try to keep it very simple in keeping it a zone aspect fitting philosophy, but the manipulation of those zones is what's important. And Dr. McColley showing you in this example that he can manipulate these zones accordingly to get the best possible fit. That could be through your reservoir zone, through your stabilization zone, and then having an independent edge really helps with not only comfort, but in some cases, the centering of the lens. If you look at the REM lens that was designed, we took the information that was already provided from previous lenses in another design and tried to adapt it to our design. We also looked at the factors of our design and how we had to manipulate them differently to get the best possible fit. The parameter ranges are set by the FDA. They're set under the approval of a particular design, but we know that the labs and manufacturers can usually go outside of those parameters if need be. And in this case, our design was limited in the diameter, but we actually went a little larger for Nick in this case, and it worked out. So you have set parameters for a reason to keep your returns down in exchanges, but going outside of those is still a possibility. And I think this is a prime example of that.
Right. So I said, Tony, this is what I need. This is what's worked for me. So we kept the base curve in 8.3, the power of 0.75. We kept the diameter in 11.5. But this is where the REM lens is a little bit different because, as Tony said, you can manipulate a zone without affecting the fit of the lens. And just like the Atlantis scleral lens that X-Cel has that I'm very familiar with, you work from the inside out. And so we started on the inside here, and the first change that we made was a much larger optic zone diameter. The optic zone diameter of the other lens that I was in was a 5.8, and this is a 6.3. And so that 0.5 millimeters doesn't sound like it should do a whole lot. But in practice, it has done a lot for myself and for other OrthoK patients. So from some of the recent studies that we've seen, the smaller the optic zone diameter, the better the treatment for myopia prevention becomes, the better regression that we get.
The peripheral defocus helps with the situation in that.
That's right. That's exactly right. So the peripheral defocus of having that smaller optic zone diameter helps cut that feedback cycle for the eye to grow. As we moved out, we kept the reservoir standard for the REM lens design and the stabilization zone standard. And then we made the dynamic edge one step flatter. And that was to help me get the lenses out a little bit easier because some of them were getting pretty tight overnight. So the results of this one, I wore it for a couple nights and was just blown away. My refraction in the morning was the same. My over refraction was the same as the other lens, but I got 20/15 or better vision throughout the entire day. And in fact, I've recently found out that even if I only wear them for 4 or 5 hours a night, I still get that great vision. There's very few aberrations. I know that I'm always going to have some aberrations because my pupil size and dim lighting is 7 to 8 millimeters. And so at night, I still get a few halos, but my vision through that halo is just phenomenal still. And so again, that's about setting expectations for your patients, especially your young ones where you're using a smaller optic zone diameter. So in the final two topographies that we have here, the topography on the left is the REM lens, then topography on the right is the lens that I started in. And that treatment zone is appreciably bigger in the REM lens than it is in the other design, starting with my left eye and then going over to the right. And you can see that it's a little bit bigger. And again, on a topography, it doesn't look like it should make that much of an impact. As a practitioner, I might look at that and say, that's not really that big of a deal. That patient was just being too critical. But after doing it on myself, I realized that that is a big deal. And so the beauty about the REM lens is that we can adjust the optic zone based on our goals. So I've been steering a lot of my patients that are over 30 into OrthoK that are too dry for LASIK or too dry for soft lenses because I myself, that's the reason I got into it. So that is one option where we can make the optic zone bigger to give them better vision, more like what they're used to in standard glasses and contacts. But in myopia management, it's important to be able to move the other direction. So it's nice that with a standard set, so if you start with a 10.6 diameter REM lens with a 6.0 optic zone, you can shift that optic zone up to 0.2 millimeters one way or the other without changing the design of the lens in order to achieve the goals that you need. And then from there, you can change the fit and the stabilization zone and the edge to make sure that that patient is comfortable and sees well all through the day, all through the activities that they need. My experience with the REMLens is that patients are generally more comfortable than in older designs, and the effects happen about the same rate, but the end result is better.
And I would just, again, try to insert a few things that keynotes here. First is data in, data out. Gathering as much data as you can. Recent data is important. As much as you can give the consultants, it will help in the end result. And then looking at choosing the right design for that patient. What are you trying to do? What do you need to manipulate with that design? And then procedure. Obviously, Nick's doing it with himself, and he's following through, probably over following through, if that's a term. But procedure is very important in this also. Following the procedure, the wearing schedule, the hygiene, and things like that. So all these things factor into it. But I think that's a great case, and I appreciate it, Nick. Glad you stuck with it and gave us that fit.
Yeah, absolutely. And the procedure in our practice, and what I stress to every, especially contact lens fitter that is getting into myopia management, is that you need to have established protocols in your office that your staff understands. You have to make your staff a part of it so that they understand the process and reduce doctor time. And your patients have to have expectations. So in our practice, we know that the first day they get the lens, they're going to put them on, make sure that everything looks good from a doctor standpoint, make sure that they're healthy lens. They sleep in it. The next day, we get some information in the morning. Now, my biggest piece of advice, and where I've messed up in myopia management in the past with orthokeratology, is seeing that first day and saying, oh, this isn't good enough. Let's make a change now. You have to give it some time. And so we see them in the morning just to make sure that everything went okay and made sure that we got some improvement. But that real first follow-up is at a week. And the more information that you can give the consultants at that week follow-up, the better it is. And we do our first day in the morning, our 1 week in the afternoon. And we do that intentionally to see what the vision is in the afternoon, see what the regression has been throughout the day. And at that time, anything that can help the consultants, topographies, videos, pictures, over refraction, which is over the OrthoK lens in the eye, and then a refraction after the lens is out. Those are all crucial factors to help make sure that your next lens, if need be, is a better lens.
Couldn't agree more. Thank you.
All right. Great information from both of you. Tony Caporali of X-Cel Specialty Contacts and Dr. McColley of Hancock Eye Associates. And thank you, X-Cel Specialty Contacts, for sponsoring this video. Thank you for watching. Goodbye.